You're listening to the Cash Podcast, creating affluence, success, and happiness with your financial surgeon, Adam Koós, President and Portfolio Manager at Libertas Wealth Management Group at libertaswealth.com.
All right, everyone. I'm here with Dr. Mike Langan, physician, internist, and fellow of the American College of Physicians. And we're going to get a front row seat to what's really going on with the coronavirus today. But before we get started, as always, a few housekeeping items. If this is your first time listening or watching, then thanks for joining us. The Cash Podcast is produced weekly and as stated in the intro, Cash stands for creating affluence, success, and happiness. And that's our mission. So my hope is for you to learn a little bit more each and every episode so that you become more successful, wealthier, happier, and more educated than you were before you started listening today. So come back often and feel free to subscribe on iTunes and YouTube. In addition, you can also follow me on Twitter at Adam Koós and on Instagram, where you can look up my username, which is at Financial Surgeon. Last but not least, all links, visuals, and charts and other educational resources are on our website at libertaswealth.com. So that's it with the formalities. Let's go ahead and get started. Normally, this podcast is aimed at financial planning, retirement planning, estate planning, investment management related topics. But I felt a discussion about the coronavirus from a healthcare perspective made a lot of sense, especially considering how much it's affecting our lives financially or otherwise. So Dr. Langan, thanks so much for taking the time out of what's probably been a very busy time for you to make this happen. I really appreciate it.
Yeah, no problem.
Now, I know you don't give yourself enough credit, and being such a modest guy, I have no choice but to let people know that you not only practiced at The Ohio State University Medical Center for 12 years, but you also have been named one of the best doctors in America, not once, not twice, but 8 years in a row. So congratulations on all your success and accomplishments as one of our leading healthcare providers here in Columbus, Ohio. And I also have to share, before I ask questions, I also have to share the story about how we met. And I don't know if you remember this. So two clients of mine, I won't use their last names, Vance and Donna, they were in here for an appointment in my office. And I mentioned that I needed a new primary care physician, and they couldn't stop talking about how much they love you. And they're just going on and on and on about, oh, our doctor's this prodigy, he's amazing, and you've got to go talk to him. So I go and reach out to your office to set up an appointment to become a new patient. And they wouldn't let me through the door because at only 32 years of age at the time, you'd gotten so busy that you already were not accepting new patients. So the next time I saw Vance and Donna, I told them I couldn't get in. And I believe what happened is they either called in or went in for the next visit with you and asked you to make an exception for me. And you did. And I thank you for that. And just so everyone knows, Dr. Langan is accepting new patients. So get in while you can, I guess. But enough about all that. Let's talk about your experience through this slow motion train wreck thus far. And I do have quite a few questions here. So let's just start with you personally. I mean, tell me about how has life changed for you at home with your bride and two kids? And I mean, are you putting in a lot of hours? I mean, is the family holding up okay? I mean, how's it been for you?
Yeah, so this is a big game changer, I think, for everybody, including myself as a physician. So pretty much everything has changed for me. So I have always been a very hands-on person. And so even at work, my preference is always to examine patients and, look at patients face-to-face and talk to them face-to-face in the same room. And since all this has started, we really have modified how we practice medicine. And that has sort of bled into even my home life a little bit. So as you probably know, telehealth and televisits has really sort of taken off here since the coronavirus outbreak. And so a lot of medical care that we're delivering is actually via video technology. So for those of us that have been technologically challenged, we're evolving really, really quickly. And so I do a lot of patient care that is still direct in terms of seeing patients in the office, but a lot of stuff is done via telehealth. And so most patients we're trying to direct to our clinics through a virtual format or through an electronic video visit. And so for me, that's been really challenging. So it's been very busy because we're learning new technology because this is still a very, very new practice of medicine. Historically, I've done, one or two televisits over the course of, maybe a couple weeks or even a month. And now I'm doing a whole lot like crazy. So the good thing is we're still delivering patient care The bad thing is you don't get to see all the patients that you want to see directly face-to-face in the office. And the other thing with that is you're able to do some telemedicine actually from anywhere that you're at. So I can start to do medical care even at home. So there's some video visits that I'll do from home. And so that has sort of bled into home life a little bit because we're trying to keep patients healthy and keep them, out of the hospitals, out of the ERs, and out of harm's way with the pandemic.
I was just going to say, being able to do that from home is probably a good and a bad thing, right? Trying to separate where does work stop and family begin.
Yeah, exactly. So historically, I would go to work at 7 or 8 in the morning and come home at 5 or 6, and now it varies a little bit. So, and we also in the healthcare system, so in a primary care office, we also don't want to continually be exposed to each other because you don't want healthcare workers to get sick from the virus en masse, because that would take us out of commission as a group. So we're trying to, some folks are working from home on some days, and then we're still doing all the social distancing even in the office when we're all in the office. So
that's really interesting. I didn't realize, I knew the teledoc was kind of a big thing, but I didn't realize how fast it became such a mainstream. So that's interesting. I mean, I think it goes without saying you've got a pretty unique perspective. I mean, literally being on the front lines and having a front row seat to this thing. But I mean, how did things look out of the gate when all the diagnoses first started popping up?
Well, admittedly, when we first converted to televisits and we first started to see people that were getting sick with fevers or, respiratory symptoms that we were suspecting were COVID, it was pretty crazy. So there was a lot of patients that we were, referring for testing and referring for even emergency room visits very cautiously because, we didn't want to spread virus just by telling everybody to go to the ER. And we also wanted to make sure that we narrowed down targeted people that were most likely to have virus so that we could test them with some of the limitations that we had in terms of testing and testing turnaround. We wanted to make sure that we targeted very specific people that were higher risk for testing positive. And we did a very good job of that, I think, out of the gate, despite, some of the chaos and all that. I think one of the first reports that I saw with the first, I think it was 2 weeks of testing, we had about 11%, I think it was 11% positive rate or turnaround on COVID testing. So, which is good. So if you look at other data from, other locations, it could vary anywhere from, 8% to a little bit higher than that. And then obviously New York is a really high positive test rate just because it's so prevalent in New York. So we actually did pretty good out of the gate despite the chaos.
Okay. I mean, I think that most people know that the primary symptoms of the virus include fever, cough, shortness of breath, and that, symptoms can still take time before they appear. But, what kind of things are you looking for when potential new patients or cases come into the office?
Yes, it varies. The illness itself is variable and depends on, age and other comorbidities and things like that. But the most common symptoms that we're seeing, at least from my perspective, is, fever, cough, respiratory stuff, as you mentioned. But I've also seen several cases that were really just more like sinus congestion, common cold type stuff, runny nose, and, maybe some subtle fatigue and body ache. So there's a whole variety of presentations that I've seen for people that have tested positive. But in the more severe illness, it's fever, body aches, it's respiratory stuff. Well, it's cough, shortness of breath. That's the more severe cases.
It's almost like diagnosis. It disguises itself as other things. Kind of tough to diagnose, I guess. Got to rule things out.
Yeah. So it's kind of funny because they test people for flu at the same time that they test people for COVID. So all the people that we screen actually get tested for flu first. And we've seen, I think when we started, we were seeing more flu cases than COVID cases. So it is still flu season, and we are still seeing positive flu tests. In fact, I just saw a positive flu test a couple of days ago, and someone I was certain had COVID, and they tested negative. If they tested for COVID, they tested negative, but for flu, they tested positive. So it does. It mimics influenza. It mimics the common cold. It's very it's a very interesting illness because it can present so many different ways in the spectrum of mild disease to very severe disease.
It's almost like one of those few times in life where you can be excited to get tested positive for flu, right?
Yeah, that's right. Yeah. So I probably would rather have flu at this point just because of the recovery time and stuff like that with COVID. So I think there's a lot of misinformation and stuff like that that's out there, whether it's through the media or even with physicians and stuff like that, because it is kind of a newer thing for us. So coronavirus itself has been around forever and typically causes the common cold, but this is a particularly virulent strain of coronavirus, and it's very similar to historical outbreaks of like SARS and stuff like that. So it's a more virulent strain. So when you hear information that, well, coronavirus has been around forever, it causes common cold, no big deal, that's true, but this particular strain is very virulent. And I think the one thing that people don't understand is, although most people do well with it, there's a significant portion of people that really do poorly. And that is where the trouble lies. And, anytime there's a complex situation, I'm a simplistic thinker. And so I was even thinking of this the other day, like what's the simplest way to simplify like why this is such a big deal if it's a virus that's been around forever that hasn't been, as devastating as it is currently. And I guess if you'd let me just say for a minute or two,
sure,
how I simplify that in my mind, maybe that'll help some people understand it. So if you imagine that you had like a city or, a population of like 1,000 people, and those group of 1,000 people, they have a hospital that services, let's say 25 people, which would be a reasonable ratio just for the sake of discussion. They have 2 critical care beds. They have 25 total beds for that hospital for normal health conditions and situations that arise just naturally. Well, if you look at some of the early data from this virus, some people do get really, really sick. If you imagine that like 20% of people require hospitalization just to support them through illness, and then say roughly, 5%, so a quarter of those people, or less than a quarter of those, about a quarter of those people require escalation of care to an intensive care unit.
Okay.
So that would be, 5%
5 out of 20, yeah.
Of patients, right? So you're a numbers guy, right? So this should be this should be there. So 1,000 people that are in the population, 200 people that require hospitalization, 50 people that require escalation to an intensive care unit, and then let's say a 2% mortality, so 20 people that die from that. So in a normal health circumstance where you had unlimited resources, those would be your numbers. Mm-hmm. Now, if you imagine a situation in which all 1,000 people got infected in some way and 200 people require hospitalization, well, if you have a 25 hospital bed, that means that 175 people, if everybody gets sick at a similar time period, are not going to have access to those resources.
Right.
And so what happens in a situation like that is you start to have mortality that increases because you don't have access to the care that helps support you through the illness.
Interesting.
So it's not necessarily the illness that's a terrible thing. It's having access to the resources to support you through the illness. So, there's a couple different camps with the situation that we're dealing with now is, should we be all in and everybody's totally isolated? Or should we just let everybody get the disease because they're probably going to get it anyways, and see what happens? And so you have to find a balance between that. So those two extremes are not good, right?
Right.
Because you can't totally shut down the economy and shut down everything because then there will be increased mortality and problems with that. But you also can't let everybody get the disease at the same time because then you'll oversaturate the healthcare system and then your mortality will increase from that.
That's tough.
So
wow.
I don't know if that makes sense or if that's helpful.
It does make sense.
But,
yeah.
That's sort of how I think of things. Again, you're trying to be strategic, but not go to one extreme or the other.
I've heard that, early on, I heard that, people would say things like, well, everybody's going to get it. And I thought, man, I certainly hope not. But I guess if that's the reality of the situation, I mean, when you diagnose somebody ultimately, I mean, what are the next steps right now? I mean, and have they changed at all when you actually find a case?
Yeah, so they're pretty similar to, I think, when they started, but there's I guess 2 ways I would answer that. So one, some patients, again, we still don't have the capacity to test 100% of patients. So there are some people with mild disease that are really low risk that are going to do well, and those people we will self-quarantine. So it is, so even if you don't have a confirmed diagnosis, but it's suspicious of COVID, it's going to be a 14-day self-quarantine. In terms of actually returning to a relatively normal situation, still probably with some social distancing, we're telling many folks that we don't specifically test for it, that as long as you are 7 days past the onset of symptoms and at least 3 days without fever, without taking any medications that would suppress fever, you can return to a social, well, I don't want to say a social gathering, but you can return to the population with maintaining social distancing beyond that. But for folks that are not having a fever, that does pose some challenges. And so I have tried to be a little bit more aggressive and say, you know what, if you're not having fevers and can't really apply that criteria, I would just do the 14-day self-isolation, self-quarantine.
Okay. And you kind of alluded to this a little bit, but how do you determine who's low risk and who's high risk and who goes home and self-quarantines versus who, gets admitted? Is it pretty simple?
Yeah. So, well, the testing algorithm for us and for most people in the country, at least in states that are not totally overwhelmed, is identifying who's a high-risk patient. So 60 or older, certain comorbidities like diabetes, heart disease, liver disease, kidney disease, or they're taking medications or have a medical condition that considers them to be immunosuppressed. Those are all high-risk people. If they present with symptoms, those people, even mild symptoms, those people really should be screened and tested. If you're a healthcare worker, you work in an environment with patients that have known exposure or have confirmed COVID diagnoses, those are people that you really should push for testing. And then any patient that has symptoms with high severity, moderate to severe symptoms, meaning that they are short of breath, they're having really persistent high fevers, really significant, aggressive like fatigue and muscle aches and stuff like that. Those are people we want to test as well. But if you have healthy people that have, cold symptoms or, really mild symptoms, low grade temperature, a little bit of a cough, those are people that probably should be tested, but would be lower on the algorithm for people that have a risk for being in the hospital. But anybody that's short of breath or in respiratory distress or really, feeling like their condition is progressing, they're getting worse, those are people that we're sending, to the hospital for a further evaluation.
Okay.
And just a quick plug for our organization. So for Central Ohio Primary Care, they actually have a great access to care sort of plan in place. So we have a lot of same-day access for patients if they need to be seen face-to-face. We have really separated out respiratory stuff from non-respiratory stuff. So our first line of action is, televisits, telehealth. If we need to escalate that to an office visit in a setting of, respiratory symptoms or non-respiratory symptoms, we strategically will divert them to a location that is safe for the respective diagnosis or suspected diagnosis. So, for example, if someone has respiratory symptoms, but you don't know if they have COVID, you don't think they do, maybe they got flu or maybe they have something else based on how long they've been sick or their presentation, we actually do have a respiratory evaluation clinic. So people that are fully gowned, fully protected from COVID, so that patients can still get care without necessarily just having to go to the emergency room, which could be a high-risk exposure site. So the organization has really adapted and developed very quickly, evolved very quickly because of the pandemic.
Yeah, it's pretty quick response considering how fast this has all happened. And I'm sure there's a lot of people at home or listening to this that think to themselves, from all the way from the hypochondriac to the person who's stubborn and never goes and sees a doctor.
Sure.
When should I go in and talk to somebody, or when should I set up a teledoc visit? I mean, what would be your response?
Well, so again, two responses. One would be, basically for any medical issue that you have, you can always access a televisit for anything. So even chronic medical conditions, diabetes, anything, I think is fair game in this day and age for a televisit. And then The other thing is if you develop fever, respiratory symptoms, you absolutely should call your doctor and let them judge whether you need to have a televisit or something that should be escalated to an emergency room or some higher level of care. But to answer your question simply, anything. So, we're the ones that will decide that. So, if you call in and you say, man, I'm having 10 out of 10 chest pain, I think I'm dying, that's probably not going to be a televisit. But that's our job to kind of tease through that and triage that. We have a lot of triage protocols in place from the minute we answer the phone to identify patients that are appropriate and not appropriate for televisits.
So bottom line,
if you think you have a health question, Adam, you or anybody, call us and we'll help sort through it for you.
Got it. Okay. So bottom line, don't be stubborn. Don't think, I'm fine. Make the phone call. That makes sense.
That's correct. Yeah. Don't be stubborn, man. Stubborn patients are tough for me to get the care that they need.
Yeah. Would you say there's any myths or misconceptions in your eyes when it comes to this virus? I know you kind of alluded to one earlier. Anything that kind of peeves you or whatever?
Yeah, well, I think there's a lot of misinformation because everybody, I would be the first to say that, if anybody, wants to call me out on something that I said is incorrect, I'm always happy to have that dialogue and say, oh yeah, hey, I like to learn and what did I misquote or what did I misspeak about? But it seems like when there's a big emergent situation or a big crisis, everybody all of a sudden knows everything. And so, so just a couple things off the top of my head, the coronavirus is totally benign, harmless disease is false for this specific virus. The other thing is that it is, going to be this absolutely catastrophic thing that nobody will recover from. Everybody's going to get sick and 50% of people are going to die. That's false. We know it's a small percentage and we're just trying to be strategic, again, so that people that really should not die from the virus do not die from the virus. And so that is, I think, the biggest thing for us that we're trying to target is be strategic so that people can do well with this. And then a lot of the, aggressive pushes for certain drugs or certain, vaccines and the skepticism of all that, like these things all need to be studied. We're data-driven people. We need to know definitively what works, what doesn't work. We need to do things safely, and we need to, again, be very strategic and not panic. And so we don't want to rush treatments or rush vaccines that do more harm than good. And so, all the people that claim that they know the answer to this whole situation, they don't.
Right.
And admitting that, we're still working through it. We're still learning every day. And we're, trying to be strategic and, do things in the good for public health and for society. That's it. I mean, we're trying to get smarter. We're trying to get better. And that's all that we can do right now.
No, it makes sense. One of the biggest questions that I hear right now is all the talk about when we'll see the peak in the curve or at least a flattening in the rate of new cases and deaths resulting from the virus. I mean, there have been so many different studies, and I keep getting people text them to me, email me to, pictures and charts.
Yeah.
I mean, there's no shortage of opinions, obviously, but what's your take on when this thing will peak? And I hate to ask you that question.
Yeah, no, that's great. That's great. So I think the reason you keep seeing different figures and pictures is because we keep pushing that back. So, Ohio's been actually really aggressive compared to many other states, and all the social distancing that was implemented like really early on by the governor has definitely blunted that curve and pushed it back and delayed it. I was kind of looking at that this last week, and it seems like, it was like April 7th, and then it's like April 14th and April 16th. But I think we're getting closer. And if you look at the numbers, mortality-wise, prevalence, incidence, et cetera, it is, we're getting there. And I think we are probably, my best guess, and again, it would be a total guess, would be within a couple of weeks, we will probably be there. 2 to 4 weeks, I think, would be, actually 1 to 4 weeks, if I'm allowed to be even more general.
Sure.
We would be within the peak and hopefully start to downtrend. And I think, so it's kind of a no-win situation, right? Because if you hit that big peak, and it sustains for a long period of time, that it's a crazy high peak, then nobody wins from that, right? Because a lot of people get sick and there's bad outcomes. But at the other side of the coin, if you totally blunt that, if you really blunt that peak, and it's a very small peak and it's very short, and we do very well, that's great. That's what we want. But then the medical community and the governor, I think will be in question as like, well, why were you so aggressive? This wasn't so bad.
Mm.
But I prefer the latter situation, because from a health perspective, if it is not as exciting as everybody had anticipated, that is actually probably the best measure of success for what we've done.
For sure.
But it's hard to process that, right? So you sort of look back retrospectively, and it's easy to be a Monday morning quarterback, or hindsight 2020, however you want to say it. But it hopefully will not be as exciting as people had predicted, and to me that would be a measure of success. So
be a win for sure. Yeah. I mean, once the stay-at-home ban is lifted, do you feel like people should feel comfortable going back to their normal lives again? I mean, or should they be concerned?
Yeah, we're going to go back to normal life, and we're going to be okay. We're going to do just fine. So, there may be some things that have been revealed to us about, workplace hygiene and prevention of infection. Again, we tend to have people stacked on top of people where we live and where we work, and there may be some changes, but anytime there's a big event, there's changes that are not necessarily a bad thing. It makes us, again, I think, better and smarter, and again, more strategic in our approach to life. So, but we'll go back to life will be normal again. It may be a slightly new normal, but it will be normal and it will be good, without question.
Maybe big companies keep their big offices, but more people work at home and they get bigger offices.
Yeah, maybe. I think the biggest thing that's going to come from this is video technology is going to be
for sure.
A platform that is, especially for us in medicine, it's going to be a platform that is implemented and embedded indefinitely. So, when we had a big meeting for our organization, somebody had asked, when is televisits, when is that going to end, or when's that going to go away? Because I want to see patients in person. And maybe I misquoted that question, but the answer is never. So televisits and telehealth is going to be here forever. And so a lot of meetings, I suspect, will be there's going to be a lot of video technology that's implemented for meetings. And again, stacking people on top of people may not be the way of doing things anymore. But so we'll get back to we're very good at evolving and adapting to new things, and we will do just fine.
So kind of piggybacking off that new normal, if you will, what are your thoughts on a potential second leg higher in the rate of new cases and heaven forbid new deaths once the lockdowns are lifted?
Yeah, I think that's a good question. So there's a couple things that I think we're hoping for. One is, you start to get closer and closer to what's referred to as herd immunity. So people that have had the virus or, had mild cases of the virus will be immune, so they won't be vectors to spread additional virus. So it becomes a little bit more difficult to spread the virus. We probably will still have some social distancing things in place that will also minimize spreading the virus. And we probably will protect our highest risk folks for a little bit longer once we get back to real things. But, again, we're going to get better. There's going to be better treatment options. Eventually there will be some form of vaccination. I got to believe that it's still probably a ways away, but we will get better, and the approach to the virus will be better. So I'm not terribly concerned about that. We just, again, have to be strategic, right? So your highest risk people, you probably want to reintroduce them back to everyday life a little bit later in the process. But many of us younger folks, I don't even know if I'm still in that category, but many of us younger folks and all that will, and people without a significant comorbidities, I think will be a little bit faster to return to normalcy.
So you kind of took the words right out of my mouth. I mean, what about your thoughts on a vaccine? I mean, what have you seen that seems to be having a positive effect these days? And I'd hate to ask you to make a prediction, but when do you realistically see a vaccine coming to market? And you can just give me a range, kind of like the whole 1 to 4 weeks.
Yeah, I would say 12 to 18 months at the soonest. A lot of, those are vetted pretty significantly, especially, there's a lot of bad press historically of bad vaccine outcomes and a lot of misinformation. So a lot of really actually bad even published data about older vaccines, flu shots, things like that. A lot of misinformation that's been difficult to recover from. So they're vetted very aggressively, safely, and there won't be a vaccine unless it's known to be safe. But yeah, I would say 12 to 18 months. Again, that would be just my best guess. These things don't happen overnight. It's kind of funny though, because I think like as soon as there was the first case of COVID in the United States, I saw a post on social media that like there was already a vaccine that they developed like overnight. And the person
somebody's backyard treehouse.
Yeah, right. And the person that posted it was like, "There's no way this happened overnight. Like this cannot be safe." But like, again, so it was misinformation about a vaccine even existing, and then somebody already criticizing the vaccine that didn't exist. So, and then it led to a whole discussion of like this was all genetically engineered, and like they already had the vaccine, and we now know that's false, right?
Right.
So those narratives tend to play out over time, and then those people kind of look back in retrospect and be like, "Man, that was really stupid," right?
I think it gets buried in the abyss of old social media posts that nobody ever pays attention to anymore. So,
yeah. So, and I actually have been on zero social media since this all started.
Probably smart. Yeah.
I've not got a single since that post. That's probably the last post that I looked at on social media. I have not used. I got all my information comes from either the CDC. There's a couple other health sites that I look at, ODH and all that, and then our organization as well. And still have a lot of colleagues at Ohio State that I communicate with pretty regularly. So pretty good resources of information for me, at least.
Keeping things unemotional and sticking to the data, right?
Yeah, that's right. I couldn't have said that better. Yeah, a lot of the emotional response is not going to benefit people. We want to be strategic. We want to be data driven. We want to be smart about things and not let our feelings and emotions drive our decisions. We want to make sure that we have evidence to support what we're doing and what we're saying and all that. So
I wasn't going to say this, but I can't help myself. There's been 2 times now where we've talked about keeping your emotions out of your decision-making. And I can't help but say that how many lines of correlation there are between what you're saying in your profession and what I'm saying in my profession when it comes to the stock market. It's crazy. But anyway, I mean, back to the story here. I mean, with the vaccine, so we talked about the vaccine, maybe 12 to 18 months. I mean, what are the chances, I guess, that the virus comes back in fall when flu season begins again? And do you imagine that the impact would be better, the same, worse than the past couple months?
Yeah, that's a great question. I think that's a concern for a lot of the medical community in terms of, peak incidence in spring and then in fall. So if there is a resurgence in fall, which is very possible, I guess what I would say now is we'll be much better prepared for it. So every day is not just about treating the virus. It's about getting better and more prepared. So that analogy that I gave you about 1,000 people and 25 hospital beds, 200 that need the beds. Well, we're creating more hospital beds and repurposing, physicians if needed. So there's a lot of contingency planning. So right now the planning is not just how do we get through the spring and get over this, but it's also what do we do if there is a resurgence in the fall. And I think we will, again, be better prepared. We'll probably have better knowledge of treatment options. We'll have a better understanding of why certain people get sick and certain people don't. We'll start to approach that herd immunity that we spoke of. So the vectors that can spread the disease will be far less. And so I'm actually optimistic that even if there is a resurgence, we'll be better prepared for it. We'll be better equipped to do it. And I don't think that we'll have to resort to the aggressive measures that we have already done for this go around.
Okay, took the words right out of my mouth. So I was just curious, do you there's no way you could predict this, but do you think that there would be a chance that they'd start closing schools again and keeping people home from work again?
Yeah, I think there's always a chance of that. But as I said, I got to believe that we're going to be better prepared for a situation like that. We're going to have better testing capability, able to identify people faster. And you could already see that. So, when we first started testing for COVID, we were having, anywhere between a 3 and 12 day turnaround for test results. And now it's like same day, next day test results. And so we, even in, in the month or however long it's been that we've been doing this. Gosh, I've even lost track of time.
Crazy? That's nuts. It feels like it's been a quarter, right?
But we've already evolved and become so much better and more efficient, and we're testing more and more people. And so I would say that we're going to be better prepared, and I'm not concerned about that. I think we are going to find a normal, whether it's a slightly new normal or a totally new normal. We're going to find a normal that's going to help the economy function, and financially everything is going to be going in the right direction and continue that momentum. And I'm excited to see that.
That's great news. I keep telling, Donna, we're getting ready to plan it's already planned, I guess. We have a vacation plan for as soon as the kids are done with school, which I guess that just means they walk away from the kitchen table. That we have a trip planned to Florida. And what would you tell people that have summer vacations planned in May and June? Do you should you stay or should you go?
Yeah, boy, that's probably the toughest question you asked me this whole time. So,
okay.
May makes me a little bit uneasy as we get into June, July again. Those are difficult calls to make. I would say, I guess what I've been telling patients is if you are a high risk patient, so you're, over 60, you have diabetes, you have heart disease, things like that, I probably would consider postponing or at least have some kind of insurance for the trip, just depending on what is going on at the time. But I do hope that we're through peak season by then. But boy, that's a tough call to make. You need more time. The political answer is I'm not ready to make a decision on that yet.
Sure.
But for the higher risk folks, I probably realistically would postpone for young healthy bucks like yourself. And your family, again, I think you need a little bit more time. And really, I think the big question is when the peak happens and how big the peak is. And when we start to see that downturn, I think that's when you'll be able to answer those questions a little bit easier. And we're just not there yet.
Okay. Yeah. It seems you mentioned something earlier that it seems crazy that it's been just a few weeks. And for me, I keep telling Donna that the first quarter just ended, and I look at quarterly charts and things like that, and do a lot of analysis that time of year, and it feels to me like it's already July. I mean, this 3 months feels like it's been twice as long. Things feels like they're slow, but hopefully the next 4 weeks are slow too.
If you talk to my wife Carrie, she'd be like, "Yeah, this quarantine's been going on for 6 months."
Right, exactly, yeah. Oh man. All right. So is there anything that you feel like I didn't ask that, I should have? Anything I missed?
No, I don't think so. I mean, I guess the biggest message I would deliver is, we'll get through this. We'll be okay. We will get back to life as we knew it, or as close as possible as we knew it. Just you got to have hopefully some confidence in the healthcare system and some of the decisions that we're making. I know there's a lot of, disagreement with the extreme that folks have gone to. I do know that, us in the health care community, nobody wants to see all the stuff that we're doing in terms of the self-isolation, the social distancing. We're social people. We all want to be together. We're trying to do the best we can to, be, again, strategic, thoughtful in terms of, how can we make sure that the public is protected and people are healthy and don't have to suffer consequences of a virus that they really don't need to suffer from. And so hopefully we will continue to strike some kind of balance that allows people to function and get back to life as normal as possible, as soon as possible. We're working on it. We're getting better. We're getting smarter. So.
Well, get some sleep. I really do appreciate, and I'm sure everybody else does, all that you're doing and your colleagues are doing. And thank you so much for being willing to come on and do this show with me. I really appreciate the time and the insight. I personally, I'm a little biased, but I personally think that, you're one of the best doctors in Central Ohio. So I bet your bride would probably argue that you're even better husband and father to your kids. So for those of you who are listening, they're looking for an amazing physician. Dr. Langan is, like I said, accepting new patients, and he focuses in the areas of cardiovascular disease, diabetes, and preventative care. Again, Doc, thanks for being here and offering so much valuable information. This was wonderful and very educational. I really appreciate it, and I'm sure our listeners and those watching do too.
Yeah, I appreciate that. Thanks for letting me do this, and
for sure.
It's great to see you.
All right, everyone. That's it for today.
In person soon.
Say again. I'm sorry.
Hopefully, get to see you face to face soon.
Yeah, seriously.
Not via video technology.
Yeah, you and me both.
Yeah.
All right, everyone. That's it for the day. We realize that there are thousands of podcasts out there and you chose to listen to ours. So thank you so much for listening. Be sure to subscribe on iTunes and YouTube. Please feel free to share this podcast with your friends. And if you want more educational information, you can sign up on our website at libertaswealth.com to receive our screencasts, videos, and articles that we send out on a regular basis. Again, you can also follow me on Twitter at Adam Koós and Instagram at Financial Surgeon. So thank you so much again for joining us, and we'll see you next time.
Thank you for listening to the Cash Podcast with your financial surgeon, Adam Koós. To see any charts or images that were mentioned in this show, or to check out additional articles, videos, and other educational resources, head over to libertaswealth.com.